I'm actually privileged to be here, talk to you guys about the evaluation of the lymph node. So, I don't have anything to disclose. So, objective of today's talk is to discuss the cervical lymph node evaluation in pre and post-operative thyroid cancer patients and why it is important. We'll review the role of neck ultrasound for lymph node mapping and assessment of the lymph node, and we'll look at the sonographic features of the lymph node, trying to differentiate what is normal lymph node and what is abnormal lymph node. So let's start like someone has thyroid nodule, had biopsy done, turned out to be suspicious for thyroid cancer or consistent with the thyroid cancer. Once we have the diagnosis, what is the base next step imaging wise? Patient would go to surgery, but before they go to surgery, what is the base next step? And why is that important? So let's look at what different imaging tests that are available today in setting of thyroid cancer. Ultrasound is the number one, and I'm going to talk about that in detail later on. Besides ultrasound, there are other imaging tests: CT scan, MRI, PET-CT scan, and iodine scan. Briefly, let's look at, so CT scan is basically, cross-sectional images, and here we have example of the CT scan. That would give you broader picture, like large field of view image, where you can see not only the abnormality, but also surrounding structures. So for example, this is good modality if the tumor size is large, like 4 centimeter and large, when the tumor has extended beyond the thyroid gland, infiltrated in the surrounding tissue, like the vocal cord and the muscle. This is very good test. When there are lymph nodes higher up behind your throat, this is very good test. And why is that? Because ultrasound cannot penetrate structure that contains air or bones. That's limitation of the ultrasound. It's a sound beam. So they are not going to go through the area that has air, like the trachea or larynx, or bone. Means if we have lymph nodes higher up under the mandible or deep down in the clavicle, we are not going to see that with ultrasound, and that's where the CT scan would help. Now, what are the drawbacks? CT scan has radiation risk, that's how it works, is ionizing radiation, and it requires the iodinated contrast to be injected in your system through the IV line. So, it is good in certain circumstances, but the ultrasound in majority of the cases is the base imaging test. MRI does not have radiation, okay, so it is good, yes. Oh, I have to stay here close to the microphone, thanks. What about MRI? So MRI does not have radiation, okay, so it is good tool, but it's very expensive, okay. It is expensive than the CT scan. CT scan is more expensive than the ultrasound, but MRI is even expensive than the CT scan. And again, it would give you the image. So here we have image of the MRI, and it would give you larger field of view image compared to the ultrasound image we have, which is small field of view. We are focusing in the one area at a time, so it would not give you the larger picture, but only the area that you want to look at, okay? So here is an abnormal lymph node on ultrasound. Because it's a small field of view and high resolution images, you can look at the internal architecture. Look for the changes in the internal architecture that can help us to differentiate the lymph node being benign, which is not too worrisome lymph node, versus cancer lymph node. What about PET-CT scan? Now, PET-CT scan is combination of the PET scan and CT scan, and they are fused together, okay? It is good tool, but it is not really good in differentiated type of thyroid cancer, which is papillary and follicular. It is good tool to see the tumor spread outside the thyroid gland in the lymph nodes, in the distant metastatic site like lungs and livers and bones, only in the dedifferentiated thyroid cancer, okay? Just terms of the imaging, PET requires the injection of the radioisotope, and CT scan is radiation, so they have radiation risk. They also require the contrast, IV contrast, iodinated contrast. And the last one is the iodine scan, which is done by using radioisotope, whether it's iodine 123 or 133, depending on whether you're looking for diagnosis or therapy. Now the iodine scan can tell us whether after surgery, if you see the activity in the area of the thyroid, there is some tissue, whether it's residual thyroid is still in there or there is local recurrence. It cannot differentiate the thyroid tissue, the residual thyroid tissue left in after surgery versus local recurrence. Iodine scan cannot differentiate between that. Nor it is good to look for the lymph nodes in the neck because of the resolution problem. It has limitation. It is good to look for the distant metastatic sites like mets in the liver and lungs and the bones. Okay, so those are the limitation of the other imaging tests that we currently have. Why it is important to do the ultrasound, looking for the lymph nodes with a patient in preoperative setting, once patient has the diagnosis of the thyroid cancer and before going for the surgery. So here is the American Thyroid Association recommendation guideline that in preoperative setting, the neck ultrasound is important to look for the contralateral lobe, means the lobe of the thyroid that does not have the thyroid nodule, but you have to look for, is there a nodule and is there concerning nodule in that, and the lymph nodes, not just in the area of the thyroid, but also on the right side and the left side of the lateral compartment. So that is one of the recommendation of the ATA. What about in the post-operative setting when someone has thyroid cancer, has thyroid gland removed? What is the role of the ultrasound there? So what the ATA recommendation is again in post-operative patient is do cervical ultrasound to look for the thyroid bed where thyroid used to be there, now is out. So thyroid bed, the central means, and I'm going to talk about different, the terminology that we use, but the lymph nodes in the central part of the neck as well as in the lateral part of the neck should be performed at 6 and 12 months and then annually for at least 3 to 5 years depending on the patient risk of recurrence. So now why ultrasound? Okay, I said ultrasound is the base first line modality to detect, to map and to assess the lymph nodes in the neck. Why? Because again it gives you small field of view images, very high resolution images. So it has higher sensitivity in detecting the lymph node, and once you find the lymph node, you have to decide whether the lymph node is normal or abnormal. And we do that by looking at the internal architecture of the lymph node in addition to the blood flow and other features. It is cost effective, it is real time, and what I mean that when actually you are doing the ultrasound, you can go back and forth. Unlike CT scan, once the scan is done, If there is problem with the scan and there is question, only way you can go back is to redo the scan. In ultrasound, you can just go back with your transducer in that area and look at that area again. So it's real time, you can go back and forth. It's non-invasive, means we are not going to inject any medication or dye or needle for diagnostic purpose. No radiation, no contrast injection. With ultrasound, we can identify and detect the lymph nodes even before they are palpable, okay? Or even they can be detected, by thyroglobulin. So in post-thyroid setting, post-thyroidectomy setting, when the thyroglobulin is high or abnormal, there is suspicion of the recurrence, whether the recurrence in the thyroid bed or in the lymph node or outside the neck. So even though sometimes the thyroglobulin could be normal, but we still find the abnormal lymph nodes. So with ultrasound, we can detect the lymph nodes even in the absence of the thyroglobulin or lymph node not being palpable. We could use the ultrasound, and we use that routinely for the ultrasound guided fine needle aspiration biopsy of the node. So once we find the lymph node, And when we know that lymph node does not look normal, it doesn't fit the morphology of the normal features, and I'm going to talk about that, and it is abnormal, then we want to confirm it is truly abnormal by doing fine needle aspiration biopsy. And that's where we use the ultrasound as a guidance to guide us to put the needle in that lymph node. And we don't do just blind stuff. We actually want to sample the area that is abnormal by ultrasound. What are the limitations? Operator dependent. You need to have expert sonographers to do ultrasound. They need to know what they are looking for. Again, you have to put your transducer in the area that you are looking for. And if they don't know where to look, put that transducer, you are going to miss it. So the people who are doing ultrasound, they need to know what they are looking for. They need to know with the machine. They need to know all the different parameters they need to adjust before actually they start scanning. Otherwise, you can make normal lymph node look abnormal and vice versa. So it's very important to pay detailed attention to the technique. And again, other limitations, as Kristen was talking about, and I mentioned earlier, that when the tumor size is too big, when the tumor is invading and extending beyond the thyroid gland and invading the adjacent structures, ultrasound is hard because, again, the small field of view, so you don't get the big pictures. In these cases, you want to see the big pictures, which areas are infiltrated, how much is extending outside the thyroid gland. When the lymph nodes are too deep, what we call the retropharyngeal nodes, they are not going to be seen by ultrasound because they are too deep and they are under the bone. Or the lymph nodes too down in the sternal notch or deep to the clavicle, you are not going to see with ultrasound. So those are the indication of doing CT scan or even MRI. So lymph node evaluation is critical, but at the same time it is challenging. It is not easy to do. And why is that? So we have approximately 800 lymph nodes in the body, and 300 of them are located within the neck. So can you imagine like 300 lymph nodes? So you are going to see normal lymph nodes when you have your neck ultrasound, whether it's before the surgery or after the surgery. Okay. Commonly, the normal lymph nodes we are going to see is called submandibular, which is higher up under the jawbone, mandible. The parotid, which is the gland we have here, again closer to the angle of the mandible. The upper part of the neck, and the posterior triangle, which is the behind the muscle that we have here, the sternocleidomastoid muscle. So you are going to see that. The size of the normal cervical lymph node varies with the location where they are located in the neck, the age of the patient, and the gender of the patient. For example, submandibular and upper cervical lymph nodes are typically larger even though they are normal. Okay, and that's because of the inflammation in the throat, inflammation, because we have pharyngitis or ears. So they are going to be even though they are normal, they would be larger. So in this location, if we see larger lymph nodes, size itself is not concerning. We have to look for other features. Okay, so that is the challenge with the ultrasound looking for the lymph node. What about the shape? The shape of the lymph node also varies in various regions of the neck, but not with the age and gender. The way we decide the shape is we look at the lymph node in the longest dimension and the shortest dimension, and we look at the ratio to decide whether the lymph node is oval shape, is it ovoid or rounded. So these are some of the challenges we have, because it's not like the perfect, like if the lymph node is large means it's always abnormal. It's not like that. You need to know where exactly is the lymph node located. So what I mean by lymph node assessment, so we are doing ultrasound, we find the lymph node, we are going to find that, right? We have 300 lymph nodes in the neck, so we are going to find the lymph nodes. So what we are trying to decide, the lymph node that we see, is it normal node, or it is big but more likely inflammatory related, increase in size, or is it related to cancer, thyroid cancer? That's what we are trying to decide when we evaluate the lymph node. And why it is important. So 15 to 30% of the patients with successful total thyroidectomy have a recurrence, and this is evidence-based in the literature. 90% of the recurrence is actually in the cervical lymph nodes. Despite of radioiodine ablative therapy, so after thyroid resection, some people get iodine treatment to ablate the residual thyroid gland. Even after that, they could have the lymph node metastasis. Approximately 60 to 75% of the recurrence will be in the cervical lymph nodes, commonly in the lateral compartment. What I mean by zone 3 and 4, I'm going to talk about that, but they are in the lateral compartment, whereas 20% would be in the thyroid bed, which is the central compartment, zone 6. The surveillance epidemiology and end results database study reported poor outcome in patients with lymph node metastases in age greater than 45 years. Distant metastasis means outside the neck and larger tumor size. So it is very critical. It is critical to look at the lymph node, evaluate the lymph node, whether it's pre-operative or post-operative setting. So what is our protocol? So ultrasound protocol, let's say patient has thyroid cancer diagnosed in the thyroid nodule and going for surgery. So those are pre-operative patients. And protocol is pretty much similar whether it's pre-operative or post-operative patient. Basically, we are looking for the lymph node, trying to differentiate whether it's benign or cancer. And then we are trying to localize the lymph node in different areas. And I will talk about why it is important, okay? And if you, yes?
Can you explain what lymph node mapping entails?
Yes, I'm going to talk about that actually. Yes, yeah. And then once we find abnormal lymph node, we want to confirm whether it's truly abnormal and cancerous, so patient can be managed appropriately, mostly by surgery. Same thing in the post-operative bed. Now we know the thyroid is removed, so we are looking for any residual thyroid tissue in the thyroid bed or local recurrence in the thyroid bed, as well as we are looking for other lymph nodes in the central part and in the lateral part of the neck bilaterally. And if we find something, we want to do fine needle aspiration biopsy to confirm or rule out disease. So as I said, ultrasound technique is the critical. It's very important to have the optimized technique, because so choice of the transducer, first thing, is the superficial transducer, which has high resolution. Okay. Now, if someone has short neck or pretty, the masculine neck, if you use transducer of higher frequency, which is typically 12 megahertz, you are not going to get much depth penetration. That's the limitation. High resolution, yes, but the poor depth penetration. So you have to choose the transducer that would work best for each patient, which could be different. So with ultrasound, we are going to get grayscale images that would give us the information about the whiteness and darkness and other features that we are looking for the lymph node. And color Doppler means, if the lymph node has higher flow, normal flow, and where exactly is the flow. Image optimization we talked about, and the position is also critical, as Christian talked about that. Supine patient would be lying in the supine position with neck extended. So we have, more exposure to the areas, trying to look at the deep in the bones and deep to the clavicle and the sternal notch. And sometimes, we elevate the head to in the larger patient population or someone who has difficulty breathing, once you put them in that position, that makes it hard and they hyperventilate, and then everything moves, then it's hard to see the area that you want to focus. We also, rotate the neck, especially when we find something abnormal. We are also trying to decide whether that lymph node is accessible for biopsy in the same setting. So if we find something and we see there are vascular structures surrounding, we rotate the neck to see if we can move that carotid artery on one side and we can come from other side. So we do that, trying to assess for the whether the lymph node is accessible for the biopsy or not. So these are the two main transducer, high frequency, linear 12 megahertz, mainly for the diagnostic purpose. And again, if there is not good depth penetration, you might want to choose the lower frequency little bit, 8 or something. And this is the transducer that we use to look at the sternal notch. Again, it's a small transducer, so it's easy to maneuver in that area, and we are trying to find the lymph nodes in that area. And also we use that for the biopsy. So let's start with, so we are scanning the patient, we see the lymph node, what features we are looking for, trying to differentiate normal versus abnormal. So lymph node is characterized by the location, where exactly is in the neck. They have some features. The hilum is the normal feature of the lymph node that we are looking for. We also look for the shape of the node, size of the node. Echogenicity means how dark or bright compared to the muscle. What is the vascular pattern of the lymph node? Is there any interval change in the size or appearance of the lymph node when you're looking at the lymph node on current ultrasound compared to the ultrasound that was done 6 months ago or a year ago or 2 years ago? And any new findings, let's say if your previous ultrasound done a year ago, nothing in that area, and now you see lymph node, then your suspicion is like, why do we see lymph node? And of course, we are looking for other features, but there's another thing we are looking for, is it new finding? So here are some examples of the normal lymph nodes. So normal lymph node is cylindrical or cigar shape. They have normally, that bright is called hilum. That's a normal feature. That's what we look for too. If you put the Doppler, you are going to see the central flow, which is hilar flow. Again, it's normal finding. And this is what we call the cortex, which is darker. Okay, so it's a hypoechoic and pretty homogeneous. There should not be any heterogeneity, means mixed area. It's completely homogeneous and dark. So this is an example of the normal lymph node. If I see these lymph nodes while doing ultrasound, I'm not going to worry about that. Okay, we don't even talk about that. Sorry, I think someone had a question here. This is another example of the normal lymph node. Again, as I said, in certain area you are going to find the large normal lymph nodes like submandibular gland. And if you see here, these are zone 1, which is in the midline, and I'm going to talk about all different zones. In zone 2, which is the submandibular area, you see the lymph nodes are large. Their hilum is big, okay? But if you look at their cortex, which is surrounding the hilum, is dark and pretty homogeneous. So even though if you measure this node, it's like 9 millimeter or even 1.5 centimeter, as long as they have normal morphology and not other features, abnormal features that I'm going to talk about, I'm comfortable that these lymph nodes are normal, okay? And we don't even talk about that. And this is good example of the Doppler flow in the hilar distribution. So you have one feeding artery, but then you see the branches going away from that central dot. And these are just the two the branches of the common carotid artery, internal and external carotid artery. So we know that we are higher up in the neck. Okay, so what are the features of the abnormal lymph nodes? We talk about the size is variable depending on the location of the lymph node, but if you look at the literature, upper limit of the maximum short axis axial dimension, and what I mean by that, the smallest dimension when we scan the patient, that give you the picture like right to left picture. And I'm going to show some examples too. But in the literature, the upper limit of the maximum short axis axial diameter for the normal cervical lymph node is 5 and 8 millimeter. And why there are two numbers is again depending on the location. The up to 8 millimeter higher up in the submandibular because they could be larger node, and the 5 millimeter for rest of the areas in the neck. Shape, rounded lymph node is typically bad. Location, again we know there is high likelihood of recurrence or metastatic disease in the lateral compartment and the thyroid bed. So when we see something there, we are always worried about that. Then look at the echogenicity, how dark and how white or bright they look compared to the muscle. And in literature, the echogenicity is variable. They have described lymph node being darker and brighter than the muscle. So it can have different appearance. Loss of that central echogenic hilum. Okay, that's we look for, and if we don't see that, then we keep looking for other features. Calcification. Now, classification could be microclassification in the setting of papillary thyroid cancer, which is like a hallmark of PTC. But in medullary thyroid cancer, you may see coarse calcification in the lymph node. The appearance of the cortex, in spite of being, the normal homogeneous, it can look heterogeneous, means there are patchy white areas in that darker background. Hypervascularity, what I mean, not the hilar, but outside the hilum, okay, like within the cortex in the periphery. Cystic or necrotic change, highly specific, when we see the lymph node with the cystic or necrotic areas, we know for sure it is tumor there, commonly papillary thyroid cancer, but you can also see in patient who has a head and neck cancer, squamous cell carcinoma basically. Yes.
So what is a necrotic change?
Oh, and so necrotic, so tumor, so when the tumor grows, right, and eventually it would start losing the blood flow. And the area that will lose the blood flow start to die, okay, it's like, so it become like fluid, there would be fluid because the cells are dying, and then there is some debris inside, and I will show you the example of that, okay. So it would look like the lymph node, but there is a fluid areas in that lymph node which is not normal. So that's what I mean by cystic and necrotic change. Yes.
What does it mean when the radiologist report says, I'm not sure if I don't see the heel?
You mean the hilum?
Yeah.
Yeah. Good question. So if you look at the literature, the hilum is normal feature of the lymph node, okay? When we see that, in absence of any other features we talked about, we know it is normal node. There are some studies who found that the loss of that echogenic areas of the hilum is been associated with cancer, thyroid cancer. However, with the experience we know hilum can be variable, okay? Sometimes the hilum is pretty thin and not in the plane of your ultrasound. So you may not, even it's there, you may not identify that hilum, okay? So it also depends on the technique. Also how experienced is the sonographer and radiologist is. So it is tough to see the hilum, especially the lymph node is small or hilum is linear and very thin and not in the plane of the ultrasound that, because when you do ultrasound, you do in different plane. So if the hilum is not in exactly the same plane, you may not see that. So it also depends on the technique. But when the report says loss of hilum, it's not very specific. So that doesn't mean that there is tumor there. There is possibility. So you could have that patient undergo fine needle aspiration biopsy to make sure there is no tumor. But in absence of other features, just simple one finding of loss of hilum is not really specific. Yes.
I was told one time when there was a hilum missing that in the normal process that the lymph node goes through to do its duty for your body, it can sometimes lose that, and then as it recovers from doing its duty, it will grow it back. So you shouldn't get all crazy about it.
Absolutely, that's what I mean. Yes, it is documented in some of the study, but one finding, rest of the lymph node is normal, and if you don't have the hilum, I would not be worried about that. Yes.
What is hypervascularity?
So that is based on the Doppler, and I will show you the images of that. So when you put the Doppler, that would tell you the blood flow within the lymph node, and it's normal to have the hilar, the flow, because that's how lymph node is being fed by that artery going in the hilum, and then the branch is going in the periphery. When I say hypervascularity, means it's not the hilar flow, but the flow other than the hilum. Yes.
Are the abnormal nodes normally consecutive, adjacent to each other, or does it skip around everywhere?
Good question. So you can have more than one lymph node in the same area, but that doesn't mean that that's the only area you can have the abnormal node, and that's where the mapping comes in the play. And I'm going to talk about why we map the lymph nodes. We are trying to look at each area systematically and once we look at, we also trying to identify is there abnormal node in that particular area, because that would change the surgical approach that your surgeon is trying to do. So yeah, it's a good question, and I'm going to talk about mapping. So here are some of the examples of the abnormal lymph node. And ignore the location right now, this is based on the mapping, we have different levels, and I'm going to talk about the mapping. So here is the lymph node in the higher up in the submandibular region, okay, so which is higher up under the bone. And we know that normally the lymph node would have that darker cortex and central hilum, but this lymph node, if you see, okay, see all these bright dots, that's calcifications. Now with people who are not experienced, they may not perceive that. Now this is, if someone cannot perceive that, that's pretty bad. But if the subtle central calcification can confuse people as having echogenic hilum. That's why experience come in play, So here definitely, the lymph node that has calcification, so is abnormal. And here you see, in different plane. So when we do ultrasound, we get two orthogonal plane. And when you see the image label as transverse, that tells me that this is right side, left side, front and back. When you have image that label long, means they've changed the transducer plane, and now you have the image that would be again front and back, but this is upper and the lower. Okay, so you have two-dimension image giving the different information of the same lymph node. So this is the same lymph node in the long image. You see all this, the dots, some of them are shadowing, dark shadowing, and why is that? Because ultrasound beam cannot penetrate densely calcified area nor bones. That's why there's a shadowing, because it cannot go beyond that area. And if you see this lymph node, again this is the whole chain, that lymph node looks brighter than the muscle, right? So that is also abnormal. It looks very bright. Normally it should be either same as the muscle or slightly lower than the muscle. And this is the carotid artery. And this, even though it looks, screamingly positive, we have to confirm, because the next step would be surgery, and you don't want patient going for surgery without confirmed diagnosis. So we sample the node, we prove it is metastasis. Okay, so what about I think we talked about the loss of hilum, and now this lymph node, good question. So here the lymph node is rounded. We don't see that echogenic hilum. I would put that in the indeterminate category, not just because there is loss of hilum, but it's also rounded. And also if you see this, Doppler, there's some flow, and again, it's not in the central like in hilar pattern, more peripheral. So it has more than one features. The loss of hilum doesn't, bother me, but the rounded shape and the vascularity at the periphery outside the hilum. So we sample that lymph node and turn out to be positive. Now here, not every nodule that we see in the thyroid bed is the cancer, okay? Residual thyroid tissue can look like, nodule in the thyroid bed. Post-operative surgical granulomas means when there is surgical clips, there is inflammatory response around that, and that can give you the appearance of the nodule in the thyroid bed. Scar tissue, all this stuff, and sometimes the normal parathyroid gland or abnormal parathyroid gland, we call adenomas, they would appear as a nodule in the thyroid bed, okay? So here is an example. Here is the trachea, and we know that when there is air, ultrasound beam cannot penetrate. That's why it looks very, you see the curvilinear echogenic line, but nothing beyond that point. So trachea, here is the common carotid artery, and we see this nodule, again very small nodule, 4 millimeter, and it has area of central echogenicity, and then the peripheral dark ring, okay, and that dot centrally, you are like, is it calcification? Remember, the surgical clip would be bright too on ultrasound. So we were not sure, and when we put Doppler, there is no flow. So because it is in the thyroid bed and there is 20% risk of recurrence in that area, we want to make sure. So then we sample that area, and it turned out to be just, no cancer, So it is just post-operative changes, suture granuloma. Another example of, so this is an example of the hypervascularity I was talking about. So say trachea, common carotid artery, and we see the very dark hypoechoic nodule lateral to the carotid artery. There is no hilum, again, that itself doesn't bother me, but when I put flow Doppler, here is the carotid artery, lighting up, which it should, but then this lymph node is lighting up like, the carotid artery, so it has a lot of blood flow. Even though there is no microcalcification or coarse calcification, because of this feature, we sample, and patient had medullary thyroid cancer, so it turned out to be metastatic disease. So here is an example of the cystic or necrotic change. So the lymph node would have tissue, it's a solid tissue, so it would look like that, okay? Whether it's abnormal, it would have different echogenicity, means dark or bright. But here, you see, I'm losing my arrow here. Sorry, here. So you see that very dark area, that is fluid. And when I see fluid in the lymph node, I know it is, the cells are dying. They are losing blood flow, and that's why it's necrotic. That's why the fluid comes from. Now sometimes you see the debris and the echogenic area because it's basically dead cells in that area, but typically it's the fluid that tells us that lymph node is necrotic. Besides that, if you look at the solid part, it is brighter than the muscle. That's abnormal, and there are few dots, and those are microcalcification. So this is very specific for metastatic disease, but again we confirm that before patient goes for surgery. Yes.
So after you have radioactive iodine, if you had cancer in a lymph node, would it die the same or would it die differently?
Good question. So radioiodine so there are different doses for the iodine. Okay. So there is a dose for the ablation, and again I'm not an expert on that. Dr. Hagen can tell you more about that. But there is a dose after surgery. Someone has thyroid resection. Depending on that suspicion level, they might ablate the residual thyroid tissue. There are some thyroid cells remaining in their area even after they do very good surgery. So they want to kill those cells. And why is that? Because we talked about the way they follow the patient is by mean of serum thyroglobulin level, right? Because that's the function of the thyroid gland. Once someone has thyroid gland removed, there should not be thyroglobulin, right? Because the source of the thyroglobulin producing structure has been removed. But if there are small cells still remaining in the thyroid area after surgery, which is not uncommon, okay, then that can interfere with the level. Because those are normal cells, they are going to produce some thyroglobulin. And so now on follow-up, when the thyroglobulin is high, you don't know whether because patient still has some thyroid gland remaining or is it tumor recurrence. So that's why they ablate the thyroid bad. And that dose is different than the therapeutic dose that they use to ablate the metastatic tumor, like in the lungs and the bones. Okay, but for lymph nodes, that ablation is not been useful to kill the tumor cell in the lymph nodes. It's the surgery is the main treatment for the confirmed tumor in the lymph nodes. So, lymph node dissection, and that's why the mapping is important. Okay, so let's move on to, so once we find the lymph node, we decide whether it's normal, abnormal. That is critical. But second thing is also critical when we are doing ultrasound is once we find the abnormal lymph node, we want to exactly localize in which area, okay? And what we call is mapping. So mapping is basically localize the abnormal lymph node in the central compartment versus right lateral compartment versus left lateral compartment. And I'm going to talk about that and why that is important. Because mapping will alter surgery in 40% of the patients, as it may find abnormal lymph nodes in different compartment of the neck. Location of the lymph node matters for surgical approach as well as to determine the recurrence rate and disease-free survival in patients with differentiated thyroid cancer, which is papillary and follicular thyroid cancer. So here's the diagram from the published paper that give us the landmark. This is the landmark we follow based on this paper is, and just to make it clear that this lymph node mapping is in this paper is based on the CT scan, but we use the same landmark on ultrasound and use exactly the same way, but originally it came out based on the CT. Okay, so here what we have, is kind of an oblique profile of the neck, and there are certain things, and I have highlighted in the color that we use. So the neck during the mapping is broadly divided in the 3 compartments. Okay, the right lateral, central compartment, and the left lateral compartment. The landmark that we use to split the central compartment from the lateral compartment is the common carotid artery, which is highlighted here in the red. So we have right common carotid, we have left common carotid artery. So everything that is between those 2 common carotid arteries is the central compartment. Anything is the lateral compartment, whether it's right or left. So those are, the right to left landmark. But there are also landmark going superior to inferior that split those compartments in different levels. Okay. Now, the compartment is critical for the surgical approach. The levels is critical for us, the people who are looking for the abnormal nodes, because we want to sample abnormal node in different level to decide whether there is tumor or not in that particular compartment. Okay, so if someone has, let's say, abnormal lymph node in the central, the right lateral, left lateral, we sample all 3 compartments to make sure there is tumor or to rule out the tumor, because we don't want patient going for the surgery if there is no tumor in that compartment. Okay, so that's why we sample each compartment separately when we are looking for the lymph node. And for the other landmark is the submandibular gland, which is below the mandible, the sternocleidomastoid muscle, which is the muscle that pops out when we rotate the neck, and the muscle on the back side, which is the trapezius. And here is, the clavicle and the mandible. So again, I'm going broadly, the central compartment, and you might hear that from your surgeon, they talk about the levels in the terms of the compartment. So when they are talking about central compartment, they are including 2 levels, level 1 and level 6. And I have highlighted for you guys, to look at the level in the blue. So the level 1 is, under the mandible, and we use these landmarks when we do ultrasound, when we label the lymph node. If we find the lymph node in that area, we label level 1 lymph node, okay, by using this landmark. So sonographers need to know these landmarks too to label the lymph node accurately. So we have level 1 and level 6. Level 1 is this one, and level 6 here, okay. Now level 6 does include thyroid bed. Remember that. But there's also area of the thyroid bed is in the level 6. So here is an example of central compartment terminology. Okay. Here we have trachea, common carotid artery, and then we have notch. Okay, in the thyroid bed, which is zone 6. And it has that tiny dot of echogenicity in the center, and tiny blood flow. Lymph nodes in this area are easier to see in the post-operative settings because the thyroid is gland. They are difficult to see in the pre-operative settings because of the thyroid gland. We can see it, but it's not commonly as we see in the post-operative settings. Okay, so that's the example of the zone 6. Now, in lateral compartment, whether it's right or left, it includes several levels, okay? Level 2, 3, 4, and 5. And each one has their own landmark, which is critical when we are doing the diagnostic ultrasound to label the lymph node. So level 2, again, is higher up here. And again, the hyoid bone determines the upper, basically it split the levels. Anything above that zone 2, anything below is zone 3 or level 3. Cricoid cartilage is another landmark. Anything below is level 4. Okay, so and the muscle and there's another level 5 back. So I put all these levels which are considered to be lateral compartment, and that's where your surgeon would talk about we are going to do right lateral lymph node dissection. And so basically he's going to take out the lymph nodes from the entire area, okay, not one level but the whole lateral compartment. So again, these are different landmarks for level 5, which is on the back side, posterior to the sternocleidomastoid muscle. Okay. So example, now this is pre-operative patients. So what I mean by that, they still have their thyroid gland. They have this nodule in the left lobe, proven by biopsy to be cancer. So when we are looking at with ultrasound in this patient, we are not done. When we find the nodule, we are not done. We keep looking. And we're looking for the lymph nodes. And what we see here, so here is the common carotid artery on the left, and lateral to that we see this abnormal lymph node. Okay, it is large, it is brighter than the muscle. When you put the flow, it has a lot of blood flow. It is hypervascular. So this is left lateral compartment. By level, it is zone 4, means it's lower than the cricoid. But in surgical term, lateral compartment. So we biopsy that lymph node was positive. So in this case, patient is not only going for thyroidectomy, but also left lateral lymph node dissection. Here is an example of the higher up level 2 node. Again, how do I know that? I see the submandibular gland and I'm above the level of the common carotid bifurcation. So that's why it's higher up in level 2. Again, it is lateral compartment lymph node and not the central. Zone 3, again, landmark between the hyoid and the cricoid, lateral to the common carotid artery. We also see the vein, internal jugular vein. The lymph node is lateral to that, so it's a right lateral compartment. Okay. Now, level 7 is actually in the sternal notch. It's deep, what we call the superior mediastinal nodes that are not easily accessible during the central lymph node dissection. So when we see abnormal node in that area, we have to be very clear in our report that this is level 7 lymph node for surgeons to know. They may not get to that lymph node by cervical, the central lymph node dissection. Okay, so like how it impacts the assessment and the mapping, how it's going to impact your staging. So we know the staging of, I'm not going to talk about the tumor staging, but the lymph node staging. And when there is no lymph node metastasis in the neck is N0 disease. When there is lymph node metastasis is N1, but then it is split, subdivided into A and B depending on where exactly is the lymph node located. So N1A is where lymph node metastasis in the central part, level 6, which is the central compartment. In front of the trachea, on the side of the trachea, in front of the larynx, which is voice box. N1B, which is the metastatic lymph nodes in the lateral compartment, as well as level 1, which is higher up, and lower down the superior mediastinal level 7 node, as well as higher up behind the throat, which is called the retropharyngeal lymph nodes. So those N1B. Now, once we have the lymph node metastasis, how is going to change your staging? And we know that for the differentiated thyroid cancer in patient older than 45 years, or even in medullary thyroid cancer, once you find abnormal node proven to be metastatic disease by FNA, it would upstage stage 1 and 2 to stage 3 if the lymph nodes are in central compartment. If lymph nodes are in lateral compartment, it would be stage 4A. Okay. So, in summary, basically we know ultrasound is the base first-line modality to detect, map, and characterize the lymph node, both in the central and lateral compartment, in both preoperative and postoperative patient setting. Fine needle aspiration biopsy is the gold standard for the diagnosis, and lymph node mapping can alter the staging and surgical planning in thyroid cancer patient. Thank you. Yes.
Do we have time for questions? I think, what time is it?
Time?
Are there, yeah, I can turn that off. I don't know.
Because I see Dr. McIntyre, so is he talking next? I'm not sure. Yeah.
So when you get the central neck dissection, are they removing like a whole area then of lymph nodes in that middle part?
Yes, and I think Dr. McIntyre is here, so he can tell you for sure. Yes, they are removing those levels that I talked about in the central compartment, which is, level 6, and about the hyoid bone. But he can tell you for sure that, right, Dr. McIntyre, you remove all the lymph nodes?
So a neck dissection is done based on anatomy, and the nodes in a group that is within an anatomic boundary is what is removed during a neck dissection. The central neck is defined as going from above the hyoid bone down to the top of the breastbone, the sternal notch, and from the carotid artery on one side to the carotid artery on the other side. Of course, you want to preserve the important structures, which would be your trachea and your larynx, your esophagus, nerves to your vocal cords, and the parathyroid glands. But everything else in that compartment is dissected and removed based on the anatomic boundaries. That's how the surgeons do that. And the lateral neck dissection is the same, it's just a different anatomic area.
Thank you.
I also have a question for you. If the lymph nodes are behind the clavicle, the metastasis will be easy to go to the chest? Is that, if they're behind the clavicle, I don't know if that will be more chance to go to the lungs or not.
Sure. So the lymph nodes that are in the central neck are really in the groove between the trachea and the esophagus. They don't stop at the breastbone. They extend down further into the chest, and they actually go all the way down to where your trachea divides into the right and left bronchus, going to the right and left lungs. So we cut off the chain of lymph nodes where it's accessible through the neck incision. And in general, most patients are not going to have cancer that will extend further down into the chest, but it's not impossible. So you can have metastasis to the lymph nodes that are going down into the chest. We call that area of the chest the mediastinum. It's pretty uncommon for people to have mediastinal lymph node metastasis. It's not unheard of. But the surgery stops sort of at the level that it's safe, and that going beyond that is not safe. And that point is generally defined by what are called the great vessels, that is, the arteries and veins that go out of and to the heart. Getting below those great vessels through a neck incision is somewhat hazardous. Staying above that is safe. Now, you've said clavicle, which is the collarbone in layman's terms. That's generally in the lateral neck to the outside or the side beyond the carotid artery. So that's a different anatomic zone. That would be in a lateral neck dissection. And again, it's the same issue. The surgeon operating through the neck can remove lymph nodes that are behind the clavicle from the neck, but going below what is called the subclavian artery and vein is somewhat hazardous. And in general, you don't need to do that because metastasis going below the subclavian artery and vein is very rare. So doing the standard operation from the neck is in general very effective. I hope that helps.
Thank you. Gosh, there's so many.
Is lymph node involvement always metastasis, or can it be primary?
Good question. So now lymph node can enlarge because of inflammatory process, someone having pharyngitis, sore throat, ear infection. They can enlarge because of granulomatous disease like, fungal infection, TB, sarcoidosis. They can enlarge because of the other primary, completely unrelated to thyroid cancer, like lymphoma or metastatic disease from other primary, outside the neck. So yes, it's not, and that's why we look for those features and trying to combine, not just go with the one. There are two highly specific. One are the calcifications and cystic changes or necrotic changes. Others are, we look for the combination of the features. And we also FNA to make sure that lymph node is truly metastatic before they go for surgery.
Can I add to that?
Sure.
I'm gonna, sorry.
Sure, yeah, no, I'd love to have you.
I'm going to interpret the question in a slightly different way. You may have not been asking this, but there's this belief that people have what's called a lateral aberrant thyroid. Is that what you were asking about? Or you've never heard of that? You know, this is when somebody presents with a mass in the lateral neck and a needle biopsy is done, and a cytologist may interpret that as normal thyroid cells. And that has been misinterpreted by some people as being a lateral aberrant thyroid. Embryologically, when your body develops as a fetus, there can be thyroid tissue that's not in the normal location. It's generally in the midline. It's not in the side of the neck. But when the cytologist says there's normal thyroid cells that came out of this mass in a lateral neck, some people have said, oh, that's a lateral aberrant thyroid. Most aberrant thyroid is in the midline. Generally what that is it's metastatic cancer to a lymph node, and the cytology may look like the cells are relatively normal. So most people that have this so-called lateral aberrant thyroid, it is not normal thyroid cells, it is cancer in a lymph node. And I have seen patients like this, I'm sure many other surgeons have, where they do a neck dissection, they find cancer in lymph nodes, they remove the thyroid, and the pathologist cannot find any cancer within the thyroid gland itself. That's probably microscopic cancer that the pathologist hasn't been able to find that has spread to the lymph nodes. So it's one of the dangers of the so-called lateral aberrant thyroid is having someone misinterpret that as being normal and then that patient not getting treated for cancer.
So there's a lot of neck metastases, and this disease also has a lot of early recurrence. And I'm just curious, what are your thoughts on whether some of this early recurrence, or the frequency of recurrence as well, has to do with just not adequately mapping the whole system here?
Yeah, and it is possible. We do see patients, who come for the ultrasound, had thyroid resection because of the thyroid cancer, just like, a couple of months ago. And they come to us for the lymph node mapping, and we see the lymph nodes in the central or lateral compartment. We sample that to prove that it is metastatic disease. And when we sample the lymph node, just for you guys to know that we sample the lymph node and send it for the cytology and also tumor marker, which is, thyroglobulin for the papillary thyroid cancer, calcitonin for the medullary thyroid cancer. So we are looking for two things, not just the one. So if cytology is positive, we are done, but if it's negative, they look for tumor marker. To answer your question, does that answer your question? Or?
I'm just curious, it sounds like in your center there's a very thorough workup. It seems like a lot of people's experience in this case, maybe not in the major centers or something like that, but it really is a lot of reoperation 1 year, 18 months later. And I'm wondering.
Yeah, I think it's probably is not, probably patient didn't go through the thorough evaluation of the lymph node prior to the surgery. And as I said, like in the 40% of the time, if you do that, that would alter the surgical planning. And not all of them, have had that before the thyroid resection. So partly when they come to us, looks like they had surgery done like a few months ago, and now we see the metastatic disease. It's not early recurrence, it's probably they didn't detect that upfront.
Hi, I'm Christy McKinney, and I, in my talk just before Nayana's, I mentioned, if you have a neck ultrasound, whether it's pre-op or post-op, and setting up a potential thyroid cancer, if they have not evaluated your lateral neck, that is a suboptimal state. We see lots of outside case evaluations with either shoddy or suspect inadequate lymph node mapping. As Nayana mentioned, it takes a lot of expertise to understand where those nodes are. It takes a lot of sonographer and radiologist expertise to understand what's normal versus abnormal evaluation of lymph nodes. And I would say just in the community, that's not something that is a standard. unfortunately. So I think your question is a true pertinent one. I wonder that myself when I see someone that has a very quick recurrence. My usual suspicion, like Nayana said, that they didn't have adequate pre-op evaluation. That is unfortunately my usual suspicion.
My question is about a lymph node, a metastatic lymph node that has been stunned by 123. Will it look the same the next time you ultrasound it? Or does it get damaged a little, or?
That is interesting. You know, I haven't heard about that the lymph node, the metastatic lymph node would be stunned by the iodine treatment. So by sonographically, you know, if there is something abnormal, we won't leave that node. I mean, we are going to sample that lymph node whether to confirm or rule out disease. Once we rule out, you know, the tumor, the thyroid cancer, when we follow up, we are going to look for the change in the appearance and the size and all other features to see if the lymph node has changed. If the lymph node looks different, then we are going to sample again to make sure, you know, there is not tumor there. So I'm not sure, is this...
I'm not going to tell. I can add to that.
Yeah, here.
Lymph nodes don't typically take up iodine.
Yes, that's right.
So they don't show up on scans because they typically do not take up an iodine. That's why surgery is the most common approach to remove those.
So why would you have a pre-surgery scan if your lymph nodes don't take up iodine?
Ultrasound.
So that's for mapping. That's for
Ultrasound, not scan.
Is this new? I had mine out in 2009, and they did a pre-scan, and that's the only way they knew that I had a whole bunch of lymph nodes that were...
Did they not do an ultrasound? Because the standard would be...
I wasn't at a place where there were thyroid surgeons. It was just a regular surgeon.
We can often detect by ultrasound, you know, the sonographic features that Dr. Patel described are detectable previous to being picked up on any PET, previous to any obvious morphological abnormality on CT or MR. We can detect them when they're subthreshold by any of those other studies because we can see things that are as small as 5 millimeters. We can look for the iron, we can assess the flow directly, we can look for microcystic cystic change. So those are things like that. Preoperative assessment is what we do routinely, so we get a baseline. So we always see normal nodes, we might see abnormal ones. Any abnormal ones will be targeted in biopsy. But after that point, we have a baseline. So the patient doesn't get a lateral neck dissection. You know, we have a baseline. We follow that patient subsequently up post-thyroidectomy, 6 months, 12 months, and will may change depending on clinical suspicion. But we have established a baseline at that point, and thereby we monitor for changes from that point on. So we would always do, because the staging can change. We can change the staging in as many as 40% of patients by doing the ultrasound first. And in this game, sorry, I didn't mean to use that word, that's a misleading word, but you want to take it seriously. You want to have the patient get the right surgery the first time to avoid recurrent surgeries later on.
Yes.
So when you have the surgery, and then you have your radioiodine, and then they do a scan after that. If they have missed lymph nodes, for instance, if they didn't go into the right side, but there's something there, will that show up on that scan post-RAI?
You mean the radioiodine scan or ultrasound?
No, if they do a scan, they scan they do a whole body scan after the radioiodine has been done for a week. Will lymph nodes show up if there is still cancer, thyroid cancer there on that scan?
So it depends on the size of the lymph node.
Oh dear.
Because the iodine scan, remember, it's a whole body scan.
Right.
So resolution, they have I think the 7 millimeter, if I remember correctly, is the limit of resolution. Anything smaller than that, you're not going. 7 millimeter. So if anything smaller than that, you're not going to pick up, by the iodine scan. Now, it is good, as I mentioned, the iodine scan is good to look for the residual thyroid tissue and the distant metastatic disease, but not good for looking for the abnormal lymph nodes because of the resolution and the.
Find any distant metastatic disease that's smaller than 7 millimeters either?
Yeah, I think that's possible, like in the lungs and the tiny mats, is the limitation of the imaging, So.